a mouthful, that one. So I'm going to hand over to you now, Liz. If you need us to do any, we'll keep an eye on the chat, myself and Craig, and you should be able to just share your screen.
That's great. Thank you, Mel. Welcome to the session and many thanks for letting our team attend today. So I'm Liz Bird. I'm the Specialist Coordinator for Primary Care Safeguarding at Northamptonshire Integrated Care Board. I work alongside two named GPs for safeguarding, Dr. Swati Negi and Dr. Rajat Sarirstafara. We are part of the safeguarding team within the ICB and will also be joined by our colleague Hope Shatiga, Deputy Designated Nurse for Children's Safeguarding. She'll be joining later on. As part of my work, I attend many safeguarding reviews. For children, these are called rapid reviews and child safeguarding practice reviews. For adults, safeguarding adult reviews, and those linked to domestic abuse, domestic homicide reviews. Safeguarding reviews are a mandatory statutory multi-agency process conducted when vulnerable adults or children have died or come to significant harm due to abuse or neglect, with a purpose to learn lessons, improve practice and prevent future incidents, rather than to investigate or assign blame. The session we are delivering today has come from the learning from these reviews. DHRs carried out in the county highlight there is little professional curiosity around domestic abuse. Even when it is known that a patient is a victim of domestic abuse, victims attended appointments for wound management, injuries, mental health, contraception, smears, etc. There was nothing recorded in the medical record to illustrate if patients were asked questions around domestic abuse and if they needed any support. Learning from rapid reviews and CSPRs has highlighted that where children have presented at a contraception appointment, for example, there's been no professional curiosity around sexual history and children have not been given the opportunity to disclose child sexual abuse. The session today, yeah.
Liz, sorry, are you sharing your slides? Because I can't see them. I can just see everybody's names on the screen.
We're not sharing slides yet. That will come.
Okay, apologies.
So this is just the introduction, yeah. The session today aims to give practitioners the awareness around identifying and responding to domestic abuse and child sexual abuse. It is hoped that it will give practitioners the confidence to ask questions in consultations with patients, as these are ideal opportunities for victims to disclose and to get the help and support that they need. Firstly, Swati will explore the topic of domestic abuse, and after the break, Rajat and Hope will look at child sexual abuse. I'm going to pass you over to Rajat to start with, because he's very famous for his Slidos and couldn't do a session without one today, so I'll pass you over.
Thank you, Liz. Thank you, everybody, and welcome to our PLT. Thank you all for attending. It's, I mean, the topics today are very, very difficult topics for a lot of us, talking about domestic abuse and child sexual abuse, and we do appreciate that even though we are all professionals, we might have faced incidences of either domestic abuse or sexual abuse in our own personal lives via our friends or families, so it is understandable if this can be a bit distressing for anybody, and if that is the case, do take a breather, do leave the meeting, etc. And the way that we plan to run the session is that the first half we will speak a bit about domestic abuse, and then we'll just take a break, a comfort break, and then we'll come back and talk a bit about child sexual abuse as well. And at the end of each session, there will be a chance to ask your questions and be answered. Though do feel free to add any questions in the chat box, and we'll make a list of those. And then towards the end of each talk, we will take those questions, and it's quite natural to have lots of questions, and that's absolutely fine. So we'll do that, and the hope really is that you feel more comfortable and more confident in being able to approach these difficult areas at all here at David Walking. And again, just to let you know that we are part of the safeguarding team at the ICB, and we work very closely with our partner agencies, i.e. social care or the domestic abuse or the police. And if we do not have any answers for you, then we can always get back to you again with those answers as required. So it's always good to know a bit more about your audience, before you start. So I'm going to share my screen now, and we'll just get to know you a bit. So it'll be helpful to have, like, your browser open, maybe a new tab where you can go click on a link, or if you got a smartphone, you can just get on the phone and you can start to use this server link from there. So if you just bear me 1 second, I shall start this off. Okay, brilliant. So the first question here is just asking you about your current role at the practice. So you can either point your phone on the QR code with the camera app, or you can go on the website called slido.com. So this is just to get you using this software or the website, but also to understand a bit more about our audience today. Okay. So far, it seems to be GPs are about 44%, followed by nurses and HCAs. I know there is some overlap between some of the emergency practitioners being nurses by background as well. Fine, we just give it a few more seconds, and then we go to the next question. I'm not very sure what the others are, but I suppose it could be medical students or nursing students or others as well. Thank you very much for. Okay, that's very helpful to know our audience. And I'm sure that the talk today will be equally relevant to everybody, including a pharmacist and paramedics and safeguarding administrators as well. Okay, next one. If I go next question here. Sorry, yeah. So next question is, how confident do you feel in recognizing and risk assessing and responding and referring a victim of domestic abuse? So be able to diagnose it, so to speak, assess the severity of it, make a referral, etc., and support them. And again, this is all anonymous, so feel free to just say what you really feel. No one's going to judge you. Yeah, and most times that we have done this survey, the vast majority are either fairly confident or not confident, or they find it difficult as well. I mean, I would put myself also in the fairly confident, and I find it difficult at times as well. So that's understandable. Okay. Okay. So it's fair to say that only 3% are very confident, which I think is as expected. Okay. And we are hoping that at the end of this talk, the numbers will change, and the people who find this difficult and are not confident will be able to be at least fairly confident, and those who currently are fairly confident will move up to very confident as well. Okay. And third and last question here. Now, how confident do you feel in documenting and recording the information about domestic? Because as you know, patients have access to their online records in many practices in the county, and that includes seeing the consultation notes as well. And it's important that we do record domestic abuse because we all share information and patients can see different conditions. But at the same time, we need to be very mindful of doing it in a safe way. So just putting it out there to find out how confident you feel in being able to record and document this information. You just wait for a minute more. Fairly confident. Okay, that's fine. So I think it's good that almost half there's a good percentage of people who at present are not confident and not sure, and we hope that by the end of this hour you will feel a lot more confident in being able to do this, because we believe it's a very important part of trying to support the victims of domestic abuse. Okay, thank you very much for that. Right, okay. In that case, so I will I'll stop sharing. So at this moment, I would like to invite my co-named GP Swati Negi, who is a GP in Northamptonshire, who will speak with us about domestic abuse.
Hi, Rajat. I hope everybody can hear me, but I'm having problems sharing my slide or getting my camera on. So this is going to be fun, but I might email you the slides. That might be the simplest way.
Yeah, that's fine. You can do that for us as well. While you do that,
I can see what the problem is. You've come in on the standard invite, not your presenter invite. So okay. I'm just changing you now. You'll be
okay, thank you.
You'll be a presenter shortly.
Thank you.
There we go. You should be able to do it now.
Oh, yeah, perfect. Right, technical hiccups. Just present in Teams. So hopefully it should start loading up now. It wouldn't let me do anything. Can everybody see that? Or somebody say yes, because
yeah,
I can't see it. Lovely, thank you.
Yes.
So like Rajat said, I'm Swati Negi. I am the named GP for safeguarding along with Rajat. And I'm talking about domestic abuse and the importance of routine inquiry and creating opportunities for people to disclose within our consultations. So domestic abuse is quite a wide topic, and but today we're going to be focusing primarily on asking the question of talking to people when they disclose during consultations, using opportunities and giving them opportunities to disclose domestic abuse, about domestic abuse if they choose to do so. But before, it's a very difficult subject, and a lot of people have faced domestic abuse in their lifetime, so it can be triggering for people. So it's very important for people to have a safe space or be able to debrief with somebody. So if you do need advice and support during this session or after, it would be advisable to speak to your line manager or a member of your safeguarding team. And also there are some contacts here you can contact if you need to. I will repeat this slide towards the end of my presentation as well. So what is domestic abuse? Domestic abuse can include physical, sexual, economic, psychological, emotional, violent or threatening behavior. It can be controlling or coercive behavior. it does not matter whether the behavior consists of a single incident or a course of conduct. If the behavior fits the pattern, it's still classed as domestic abuse. So any incident or pattern of incidents of controlling, coercive or threatening behavior, violence or abuse between those aged 16 or over. Below that, it's child abuse, but people 16 or over with people who are or have been intimate partners or family members. And this is regardless of gender, sexuality. This is considered domestic abuse. Why is it? So why are we talking about it in health? It is a health issue. There's an RCGP, so amongst primary care, the Royal College of General Practitioners, there's a safeguarding toolkit, and there's domestic abuse learning. So people can click on the link and get to the e-learning. 75% of domestic violence results in physical injury or mental health consequences to women. So it is not a victimless problem. Domestic abuse is a leading cause of morbidity in women aged 19 to 44. It is greater than cancer, war, or road traffic accidents. That is why it is a health issue. And we've noticed, research has found that there's extensive contact between the women. So we're using the word women. Yes, men are also as victims of domestic abuse, but primarily it is the women who are impacted more. So I'm using the word women, but you can use men as well interchangeably. So there's extensive contact between women and primary care clinicians. So whether it's doctors, nurses, healthcare assistants, for a 5-year period before it comes to light. So with 90% of all female patients have consulted their GP over the 5-year period. It's estimated that 1 in 8 of all suicide or suicide attempts by women in the UK are linked to domestic abuse. 80% of women in a violent relationship seek help from health services. So not the police, not the social services. It will be health that it's contacted by the women first. And it's usually the GPs at least once. And it may be their first or only contact with professionals. So domestic homicide reviews have also found that actually it might be health they're contacting rather than the domestic abuse charities or police. About 30% of domestic abuse starts or escalates during pregnancy. 1 in 4 women who are in contact with mental health services are likely to be experiencing domestic abuse. Safe Life analysis suggests that approximately 51,000 NHS staff are likely to have experienced domestic abuse, and this is just in the 12 months, in the past 12 months. And on average, victims will experience abuse for around 3 years before getting effective help. And they would have visited their GP practice on an average of 4.3 times during that period. So it is a big problem, and the primary contact appears to be within primary care, and therefore the reason for this PLT. And it's not just GPs, it's practice nursing team, it's the healthcare assistants, it might be the reception staff. So what are the facts? Like we said, 1 in 4 women will experience domestic abuse in their lifetime. A woman is killed every 5 days by an abusive partner or an ex. Police will receive a call for domestic abuse every 30 seconds, and it can cost the economy up to 66 to 78 billion annually. There's a little video. It's made by the WHO. So I'll play that. Hopefully it'll play. Please somebody tell me if it's not playing.
You need to enable your volume because there's no volume coming through.
So I need to enable my volume on the display settings.
So it's under it's where you share.
Yeah.
If you click on the share button, right at the very top, there's a thing that says include sound.
Let me just have a look. That's it.
Yeah.
Perfect.
Their lives are often restricted. Those who consider leaving often fear ending up penniless or losing their children. Over time, their confidence slips away, making a life without violence seem a distant memory. The abuse can lead to injuries, as well as serious physical and mental health problems, in some cases, even death. Many women contract sexually transmitted infections or have unwanted pregnancies, and when pregnant, have a greater risk of miscarriage or of having a premature or low birth weight baby. They can experience depression, anxiety, other mental health problems, or become addicted to drugs and alcohol. It can be hard to know who to trust or where to turn. But there is a place that a visit to a local clinic is often one of the few opportunities women have to go out alone. And it's important for doctors and nurses to make sure this isn't a missed opportunity. When doctors, nurses, and midwives listen with compassion, survivors are more likely to share their story. When they ask the right questions, they can uncover what is really happening and challenge cultural attitudes that say it's okay for a husband to hit his wife. They can reassure women that it's not their fault and can work with women to help them stay safe. And where necessary, connect them with other services that can provide, for example, shelter, psychological support, legal services, and financial opportunities. More women can find their way to a life without violence when changes are implemented across healthcare and other systems. Changes such as private rooms for consultations, training that enables doctors and nurses to respond better to women's needs, and raising awareness of the harmful consequences of violence for women and children and how to prevent it. Making these changes helps foster a culture where violence is unacceptable and where women have the courage to speak out. Imagine if that could happen to each and every one of those 800 million women.
So as people can see, it is not just a UK problem, it is a worldwide problem. And as the video said, 800 million women across the world are experiencing it. So it's really important for us, at least within the UK primary care, to take this issue and learn to be more open about asking questions about this, because it is that common. So how do you know, how might you know that your patient is experiencing domestic abuse? There are some physical and mental health issues that have a strong link to being a victim or survivor of domestic abuse. And that is a lot of people we see in primary care, people who are presenting with anxiety or depression, PTSD, chronic pain. They might present with difficulty sleeping. They might have facial or dental injuries, history of alcohol, drug misuse, pregnancy, request for termination, miscarriage. All these are times where women will consult GPs or GP practices. And these are all opportunities we can ask the question. There might be unexpected injuries to breasts, abdomen, to intimate areas, sexually transmitted infections, recurrent urinary infections. There might be a history of somebody saying, I've had unprotected sex. There might be nipple lesions, etc. So when patients, whether it's adults or children, they're presenting with these issues, it is important to inquire about, obviously, the reason they're feeling like this, but also about domestic abuse. Also remember, this can indicate other various forms of abuse and neglect. So it's not just domestic abuse we need to be concerned about, it could be other types of abuse. So how do we address it. So domestic abuse, we like to think of it as trying to recognize it is, reach out to the person, respond to it properly, do a risk assessment, refer, and more importantly, record this correctly, appropriately in the electronic medical records. There will be one more video. There's a couple more, but this is the next video. Hopefully this will play.
Usually there's an instinct. Most of us will walk into somebody's home or we'll meet somebody and we'll instinctively know that something's not quite right. But that's not enough. They don't always give us that information. Just because the hairs are up on the back of your neck, it doesn't mean that somebody's going to blurt out what's happening in their lives and what their problems are. Most of us, a lot of people don't even realise that what they're experiencing is abuse. You know, there will be aspects of it where actually you are being controlled. You're not being allowed to go and see your friends when you want to, but there's always a very reasonable explanation. But actually, it's not okay.
Yeah, and that's very true. It can be very uncomfortable initially asking those questions, but I think if we just start to try and encourage everyone doing it as a part of a routine assessment, so that everyone has the opportunity to have that really safe space where they can open up about it. And quite rightly so, you said again that not many people, or not all people, will know that actually they are being subjected to domestic abuse, and they will feel that it's normal. And I often find that a question, so if you start to get that instinctive gut feeling, a question such as, so tell me about your relationship at home, what it's like on a daily basis, just gives them the opportunity to have a discussion with you, and for you to use that instinct to discover actually if there is some abuse taking place there. And from there, you can ask the questions such as, and do you feel safe, and how does that make you feel, and really open up some qualitative questions so that they can give you some good examples of what's going on, and therefore you know if you need to make any referrals onto First Light, which is domestic abuse organisation, or adult safeguarding, or contact the GP, and to explore what it is that they feel that they need. Because I feel once you actually open those gates and you have that discussion, then they'll be able to actually see for themselves, oh, actually that isn't comfortable, and what is happening isn't okay.
And it's that feeling of being comfortable. I mean, we refer to the routine inquiry question as, do you feel safe? But sometimes that's not just what it is. You can feel very safe, very secure, but a cage, however well gilded, is still a cage. And actually getting people to recognise that perhaps they are being controlled. Are you allowed to do the things that you feel as though you want to do? Is that okay? You know, it isn't just about feeling safe. It is also about feeling controlled.
Absolutely, and you can again elicit the information from the questions that you ask. So if you're saying, you know, for example, how much do you have contact with family members or friends? Is that something that you do regularly? Or talking about medication. So it's often these little sideline conversations that we're having that you can tend to get a feel of what's going on in the relationship. Because like you said, a lot of people, they won't feel that there isn't a problem, or that there is something that they need to disclose. But when you're just having these conversations, then it's that sort of time when you can, you know, find out exactly what's going on within the home without potentially being as direct as that. You know, do you feel safe? So if you found out that actually it's controlled how often and when they watch the TV, or not allowed to go and pick medication up, or that friends aren't allowed to come over, sort of all these little areas, controlling money, all the finances, all of these sorts of areas, that then you can start to pick up on it.
So, as the video said, abuse can be quite subtle, and we can ask a question in a different way. So, this is the whole topic. How do we ask the question? First thing is to have that professional curiosity. So recognize and ask. So pick up the cues. Tell me more about. It doesn't have to be, do you feel safe at home? It could be, oh, you mentioned this. Tell me a bit more about. So it's really important to have professional curiosity. It's quite natural that all of us want to think that, in the best in people, that everybody is happy, we are optimistic, we're quite okay to accept somebody's view if they're presenting in a certain way. But thinking the unthinkable is not about assuming the worst. It's considering all possibilities during a consultation. So it's important for us to keep an open mind. We should be able to think objectively about the evidence presented, and has it changed over time? Has the story changed? Was the bruise because they bumped into a door? Or did the story change over time to being hit by a ball from a child? So it's very important to look at what you're being told and just have that curiosity. Does something in the story not sit right? Be prepared to accept the information that does not fit with previous assumptions or assessments. So you might feel, you might see a couple and you might feel actually they're a really good couple, but suddenly the wife sees you alone or the husband sees you alone, and they say something that doesn't quite fit in with your assumption about the couple. It's really important to even accept that information. You have to accept it with an open mind. And we also need to think outside of the box, beyond our usual professional role. So it could well be they're coming for a blood pressure review, and we are so focused on doing their blood pressure that we might miss some of the cues that they're talking about. So it's really important to think a little bit more broadly. So why are we focusing on routine inquiry? Why is it so important? So a majority of the domestic abuse death reviews, so domestic abuse related death reviews, the person has not been heard at MARAC. So MARAC is the place where all the domestic violence cases are heard and discussed. So quite often they have found that in the majority of when a death has happened, this person has never been known to MARAC, although they have been seen by a healthcare professional. So therefore, we're trying to make it really easy for people to ask the question, and it's really important that people ask the question. Victims and survivors overwhelmingly report that they wish a health professional had asked them the question and then provided them with a way to disclose the abuse. So when interviews with victims and survivors, they have actually reported that they had wished somebody had asked them the question. So it doesn't feel intrusive. The person who's a victim or is surviving abuse really wished somebody had asked them. So it might not be the right time or the right day, but actually research shows that at some point they will disclose. So they may not disclose to you there and then if you ask the question, but you have sowed the seeds. So it's important that a seed is planted that enables them to respond the next time they are actually asked. So, and the lack of professional curiosity was a common theme amongst these reviews of the domestic abuse related deaths. Early intervention is the key to reducing domestic abuse and actually improving safety and health outcomes, both for the people involved, both for the victims as well as their children. So this is why it's so important for us to make it, or for us to think about it when we are consulting in any form. What are the benefits? So it breaks the silence. So domestic abuse is often shrouded in silence and secrecy. So safe routine inquiry is what it's being now called. It encourages open conversations and makes it easier for survivors to share their experiences and seek help. It offers support. So victims may feel isolated and helpless because that is part of the abuser's mode of working. They will isolate their victims. They will control and coerce their victims. So initiating conversations lets the people know that there is support available and that they're not alone. This can be the critical step in helping survivors access the assistance that they need. So it's really important for us to make it part of our routine consultations. And it helps with prevention and intervention. So if you have an open discussion, it can often lead to early identifications in abusive situations, and it allows for timely intervention. It is crucial for preventing further harm and also provides the necessary resources for the victim to kind of break that cycle. And it also challenges the stigmas and stereotypes. So it's the domestic abuse is because it's such a secret and it's people and people are so silent about it. There's also often a lot of stigmas and misconceptions, and it actually just talking about it routinely challenges some of those stigmas. What are the other benefits? It educates the community. So it could be that the person you are speaking to is not being a victim of domestic abuse, but actually it allows them to recognize it if one of their loved ones is being impacted by it. So it provides an opportunity to educate communities about healthy relationships, about consent, about conflict resolution, and it tries to create a culture not just within our primary healthcare teams but also within society that kind of rejects and hopefully prevents domestic abuse. It also promotes empathy and understanding. So individuals, by discussing it, we kind of develop a deeper understanding of how complex the situation is, and it can lead to more supportive and informed responses for people who are suffering or who have suffered domestic abuse. Fear and shame will often prevent victims from reporting it. So if we are open about it, if it's part of our routine inquiry, it actually encourages people to report it. And it also creates a safe environment. So survivors, people who are currently victims of abuse, feel that actually they are being heard, and it is crucial to breaking that cycle.
Routine inquiry involves implementing a set of standardized questions about domestic abuse during routine health assessments or consultations, regardless of whether there are obvious signs or symptoms.
Okay.
Ensuring that the inquiry is conducted in a private and confidential setting to encourage honest and open responses from patients. Healthcare professionals and other staff are trained to ask these questions sensitively and to respond appropriately to disclosures of abuse. And we must have a non-judgmental approach, creating environments where patients feel safe and supported without fear of judgment or repercussions. Consistently applying routine inquiry across various settings and patient groups ensures that no one is inadvertently overlooked. Early identification in routine inquiry helps identify victim survivors of domestic abuse who might not otherwise seek help or disclose their situation.
So how do we do it? Now we realize it's important to ask, it's important to make it routine, and it's important to think about it. So what can we say? So first thing is we have to ensure it is safe to ask. So try, and it needs to be in a private environment and when the person is alone. So is it conducive to ask? Is it safe to ask? And never ask in the presence of another family member, friend, or a child over the age of 2 years old, because the children can report back to the abuser. Create an opportunity to ask the question. So if you are suspecting something and you feel the person is not in immediate risk, you might want to create another opportunity to ask the question. You may want to say, oh, I wouldn't want to see you back for a follow-up. And you might want to discuss it. If it's a nurse or a healthcare assistant, you may want to discuss it with your safeguarding lead GP before bringing the patient back. And it's really important, if you have language barrier, to use a professional interpreter. Do not ever use a family member, because again, that puts victims at higher risk. So frame the topic first and then ask a direct question. So you could say, that violence in the home is common, so we ask patients about it routinely. And then you can ask the question, are you in a relationship where someone who's hurting you or threatening you? Did someone cause these injuries to you? If you're seeing somebody with a bruise or an injury, you have to validate what's happening to the individual and send an important message to them. You need to tell them they're not alone, they're not to blame for what's happening to them, and you don't deserve to be treated this way. Important to assess the risk. Assess the patient's safety. Is your partner here with you today? Where are the children? Do you have any immediate concerns? Do you have a place of safety? To act on it, so there are some local domestic abuse services. There are national domestic abuse services. If children are involved, we have the MASH team for referral, and any safeguarding concerns, it's really important to speak to your organization lead. So normally that would be a safeguarding lead GP in primary care, or you may have a safeguarding team that you may wish to contact. There are also the named GPs and the primary care safeguarding team that we work for the ICB. So our emails are available. It's really important also to document it, but when you document it, please consider, is it safe to document, and does the perpetrator have access to the patient's records? When you're doing the medical recording, we'll come about how to record it in a bit, but it can be used by survivors for future criminal investigation. So it's really important that when it's recorded, it's factual recording, it's not an opinion, and it is very clear language. So how can you incorporate this into your practice? It is best practice to use safe routine inquiry about domestic abuse to every patient you speak, if it is safe to do so, because you never know who needs to hear the message. And somebody might not say yes, but you've kind of sown that seed. Words that can help you. What can we say? We talk to everyone about the support available to those by domestic abuse, to raise awareness in case the individual is an affected person personally, or they may know somebody. Many people are not aware that experiences have started to form a pattern that sometimes escalates. So it can be helpful to share information. Would you like me to tell you a bit more about it? Would you like me to send you a link? When you're sending links via telephone, please be careful, because the abuser may have access to the person's phone. We could just say we talk to everyone about the local specialist services in your area in case they're affected by domestic abuse. And it's hard for people to talk about it, so we raise it with everyone. Make it routine. Make it like this is done for everyone, not just for the person you're suspecting is suffering. We can offer to put you in touch with the specialist services if it is useful. Sometimes they might say something that might trigger a thought pattern, and you can say things like, oh, you say you're finding things a bit difficult. Can you tell me a bit more about that? Can you tell me more? Tell me more about this. Let's explore that a bit further. Okay. So some other words that can be helpful. Tell me what your day looks like. Has anybody upset you? Are there things that happen at home that are upsetting or frightening? Do you feel that you're doing things that you don't want to do? Do you feel concerned about your safety? Do you feel safe? Is anybody trying to control what you do? Okay, so are there any issues at home or elsewhere you would like to discuss with me? So giving them that opening, even though they may not open up to you there and then, plants that seed, allows them to see you as a safe space where they may be able to disclose things when they feel. So if somebody does disclose, what do we do then? How do we respond? You have to make sure that they feel they are believed, they are validated, and they feel they can trust you. It is a very difficult thing for people to disclose, and they're already frightened. They're already under some kind of coercion, some kind of control. They may not have the financial means. They might be worried about their pets, their children. They might be worried about their life. So it's really important that they feel they are believed. If they have trusted you with that information, it's important that they are believed and they're validated and they feel they can trust you. So how do you respond? You actually thank them for telling you, and you acknowledge that it must be difficult for them. Ask and listen, but be very non-judgmental. Ask what you can do to help. Consider what the current level of risk is and then respond appropriately. We'll talk about the risk assessment tools, but the important thing is to assess that risk, because this is a safeguarding concern. Please do not minimize or dismiss the abuse. Don't tell them what to do, and don't ask, why don't you just leave? This one is victim blaming, but also it is when they leave, this is the highest risk time for the victims. When the abuser is blocked from access to their victim, that's when the risk of escalation happens, and that's where people can get injured or killed. So just telling them, why don't you just leave, is not safe. So how do we risk assess? We can use the GRACE tool or the SPECS. So GRACE tool is in the Ardens template, and SPECS, I'll just talk briefly about it in the next slide. We also need to assess the risk to pets. We need to assess the risk to children, because if there's ongoing domestic abuse, this is an automatic referral to MASH. This is a children's safeguarding concern. So it's almost sometimes easier to refer when there are children in the house, because we know there's an automatic referral. And there are links to suicide as well as homicide if people are in abusive relationships. So the people become much higher at higher risk in abusive relationship. What is the SPECS toolkit? So SPECS assessment is used by some of the police forces, and it increases the risk amongst these. So this is time where the risk increases of somebody being killed. If they are separated, so separation. So is the victim planning to leave the relationship or has recently left? Is the victim pregnant or has recently given birth? Is there an escalation in the pattern of behavior? So the abuser might just shout at them initially, but they might have punched them, and that is an escalation in their behavior, and that is an increased risk to the victim. Is there cultural isolation? So it could be somebody from a different country who doesn't quite speak the language, and if there's cultural isolation, that increases the risk. Is there stalking and harassment happening? So girlfriend broke up and somebody is stalking, she is now being stalked and harassed, whether it's online, whether it's physical, that increases the risk. Is there a history of sexual assault? And is there suicide or an attempt to self-harm? So all these things increase the risk. Where can we refer? So we now know hopefully how to respond, how to do the risk assessment. Where do we refer? So we can refer to DASH, or there is a MARAC referral, so you can do the DASH form or the MARAC referral, but it is a very, very long form. But if we straight away refer them to the Sunflower Center or one of the domestic abuse charities, they will do the forms for us. So MARAC does not need patient consent and is suitable if urgent. So, but it's not as urgent as 999, but you would have to do the form. I think the best thing would be to refer to the Sunflower Center, and then they can do the risk assessment as well as the form. And we won't be informed of the outcome of the MARAC. So we don't get those outcomes, but there are some safeguarding coordinators that do attend MARAC meetings from the practices, but also recently our safeguarding team has made contact, and there is an offer which Liz can talk about if people are interested, about somebody from the GP practice maybe attending MARAC for your own patients. The next bit is, how do we record this? So it's really important to think when you're recording it, but also hiding it from online record. It's really, really important, because people may have access to the victim's medical records, and therefore the risk to them increases. So have we captured the exact words, patient or child? They have to be exact words. And have we shown the level of risk and why I am worried? Because would it provide enough evidence in the court setting? So quite often some of these cases can fail if the clinical records said that the patient alleges. Okay, if you use the word alleged, then it makes it feel like the professional did not believe the person reporting it, and therefore the courts can often not agree with that. So document the actions taken, safety netting and referrals. It's really important to document what did you do, what safety netting did you provide to the patient, and if you did any referrals. What did the patient agree to? What did the patient decline? Really important to hide all information from online access, not just safeguarding relevant. Okay, so if you make the information safeguarding relevant, some staff may not be able to see it because their smart card may not contain the relevant codes. Family records is really important to link them and also document anybody who was actually in the consultation, as well as the names of the alleged perpetrators. So it's ideally use the word patient reports and then use within inverted commas, you can use the patient's exact words. So it's very important that documentation is done in that way. And also when you're putting a code in, it's put history of domestic abuse in case it is accidentally seen. So that phase, history of domestic abuse, kind of makes it that there might have been domestic abuse in the past. So it's a little less obvious than current domestic abuse or domestic abuse. Okay. Exclude the information and redact information about domestic abuse when a SAR is requested. Subject access request, really important somebody goes through it and safeguarding relevant domestic abuse information is removed. Okay, and do not include any of this information in the perpetuator's records, because unless they have told you about it, please don't do it unless they have themselves told you about it, because it's not good, because they have access to their own medical records and it may put the victim at higher risk. And be very careful when you're writing referral letters or sending people to A&E with a printout of the summary, because actually some information is automatically included. So really important to read what information is going out of the practice. And also assume that the perpetrator has access to the victim's electronic records. So just be mindful of the language we use. The next bit is about referrals, but I mean, I'm just conscious of time. Have you got enough time?
Got another 5 minutes, Swati.
5 minutes, yeah. So there is some about, should we be referring any child who's under 18 if you're doing an adult safeguarding, but not necessarily automatically, but usually important when domestic abuse is involved. There is some information about that there. And if you're not aware if the child was present during any of the episodes, should we only refer child to MASH if we know? Actually, presence is not required to meet the threshold for referral. So if you feel that there's domestic abuse in the house, whether the child was there or not doesn't matter. It is important still to make that referral. And this is all about whether we should be referring any adult parent if we submit a MASH referral. So if you feel that a child under the age of 18 has disclosed something to us, yes, it's important to consider an adult safeguarding referral, but it's really important about information about consent as well. So if the threshold for an adult safeguarding referral was met, it is highly likely that the threshold for MASH referral was also met in any children in the household. And MASH's role is to triage risk, to coordinate the information, and to determine proportionate response. So they don't need to assume harm has already occurred. They're triaging the risk and coordinating the information. And the last bits really are about who is involved within the practice. So why is this information relevant and who is this information relevant to? All the things that we have talked about. Basically everyone. Okay, so any clinician that has seen any information, online triage, via consultation, via patient letter, prescribing team who's at the front desk, over the phone, online query, because you might be getting these. And it's really important for all of us to be aware of how disclosure can happen and for all of us to be able to create that safe space for people to say something to you. It could be our receptionist, front desk, over the phone, might have seen something on online triage, our scanning teams, letter, phone call, email, our care teams, which are the care navigation teams, or the care, CCT, our safeguarding team, and anyone else in the practice that I've not mentioned. So if you're working in primary care, this information is relevant to you, because actually you might be the one person that victim sees, and creating that opportunity for them to disclose it. Any information is really important. I'm going to end with another video. That's only, I think, 3 minutes. So
So I think the sound is not there.
It's not showing again. All right, I may have to. I thought
It looked like it was in slow motion.
was it? Okay, I'm just going to try again. See if that.
Sometimes I think that if I could escape, if I could get behind the right curtain, if I was asked the right questions, ask me. Charlo was always beside me, always near, but if I got the right doctor or nurse, I'd be safe. They'd see. They'd take me away. They'd take me through a door, and I'd be gone before Charlo knew it. I'd have the kids out of the house before he even got home. We'd be gone without even having to look at him again. They'd help. They'd do it for me. If there was a room up in the hospital where we could stay, a place we'd never find us with huge windows and a balcony, the right curtain. I just have to be in the right place in the right queue. Open sesame. I'd be led behind the right curtain. It would be over. I'd be mended and safe. We'd be happy and safe. I get worked up, waiting. I believed it was just all a matter of luck. Maybe this time, a nurse would look at me and know. A doctor would look past his nose. He'd ask the question. He'd ask the right question. And I'd be able to answer it and it would all be over. Charlo was always with me. He was always there. Behind the curtain was the only time I was alone. His shadow on the curtain. A few minutes. One question. One question. I'd answer. I'd tell them everything if they asked. Ask me. I'd have told them everything. I swear to God I would have. If they'd have asked. I'd have whispered it. If they'd have asked first. He pulled my arm behind my back and lifted me off the floor. It would have been easy after that, watching them listen. He hit me. He kicked me there. He burned me here. He did it. He did it. Save me. I'd have told him everything. I just had to be brought behind the right curtain and ask that right question.
Ask me. Ask me.
Ask me.
How do you expect me to tell you if you don't ask the question?
Ask me.
Ask me.
Just ask me.
I need the opportunity, just that one opportunity to share.
Ask me.
Ask me.
Ask me.
Could start by, are you okay? How are you feeling? What's life like at home? How are you and your partner? How are you and your children? It's as simple as that.
Ask me.
Ask me.
Just ask me.
I don't expect you to fix things. I just need someone to listen to me.
Ask me.
Just ask me.
It's about taking that first step. You may be scared that no one's going to believe you, no one's going to listen, but once you've opened up and you've released, it's that light at the end of the tunnel, and you know you're soon going to be safe.
Ask me.
Ask me.
Just ask me.
I'm just so thankful somebody asked me that first question.
Thank you.
Thank you. Thank you. Thank you.
Thank you.
Thank you.
If somebody discloses to you and you need advice, talk to your manager or talk to somebody from safeguarding.
That's a very powerful video, and this was the reason we did this presentation today. It is really important for us to feel confident, or at least think about asking the question. We may not have the right words, but we have given the person the opportunity. I've sent the links again, and this is the contact. And this is a difficult topic, and as we know, 1 in 4 women of 1 in 4 people will be suffering domestic abuse. That could be somebody you know. So if you do need advice or support during, after, please speak to your line manager or the member of your safeguarding team. Thank you.
Thank you, Swati. That was very helpful and very moving as well. And I'm wondering maybe if you can spend 5 minutes on the documentation and the GRACE toolkit very quickly. Would you like me to do this, Vadi, or do you want to do that? Shall I do that? What do you think? Hello?
It looks like she's frozen, Rajat.
Okay, fine. So, well, what I'll do now is very quickly show people. I mean, I have got system one, but not EMIS map, but the same context applies, As Swati said, it's very important to really keep the patient safe. So it's very important that we do document the information in a safe way. So if it's okay with you, I'll just spend 5 minutes to go through a couple of things with you. One is the GRACE tool, which is for GPs to quickly assess as well. And secondly, I'll just show you how to hide the information as well. So I'll share my test patient called Britney Spears. So I shall share my screen, and I hope people can see everything here. Yeah. So when you're in a patient record, if you want to know what questions to ask, if you go on the orange arrow on the right side in system one, I think in EMIS there could be something similar as well, and that's where we go for our 2-week wait, etc. There is a tab there for safeguarding. And under that, the second form is called the GRACE, which is the domestic abuse questionnaire, which would help you to actually ask the right questions. And this form can be accepted by Sunflower as well, instead of doing a dash form, which is a much lengthier form. And essentially what it does is it asks 2 sets of questions. One is around control and coercion, and the other bit is around physical harm, as you can see here. And the questions are about the altering of behavior, influencing what you wear, restrictions of who you can see, do they monitor your activity when you're apart, do they belittle you or humiliate you. And the risk is never no. It's either a lower risk or a higher risk. So, and then you go to physical harm, because we know these are the risk factors which do increase the risk to a victim: separation from the perpetrator or making plans to separate, current factors with risk, previous physical assault by the perpetrator, or a recent physical threat, or a fear as well. And there are some things like pregnancy or having children in the house, and as Swati mentioned, cruelty to animals, previous police call-outs. And this is a quick way to do this in your 15-minute consultation, to ask these questions. And then you can potentially grade it as either a standard, a medium, or a high risk. There is no low risk. And then it does explain to you a bit about the rationale of the GRACE tool as well. So do please use this tool to help yourself if you are stuck as to what questions to ask. And then when it comes to documenting, so say if I'm doing a consultation and I spoke about patient, spoke about her fear of partner, etc., and you do everything else, it's very important because the patient can access things. So if I can put down here, it is suspected, for example, suspected domestic abuse, or anything which you want to put down here, and any plans. If we do not hide this information, this can be visible on online access. And because a big part of domestic abuse is control and coercion, they might have passwords, a password to their NHS app or the account as well. So it's very important to be able to hide this. So there are many ways of doing it. You can either go to the event details, and you can untick this box which says visible in online records. Or the other option is when you are, and it will ask you for a reason, and you can put down safeguarding. So there has to be a reason why you're doing this element. Or if you are in a new journal, and if you have already documented and you want to go back to it and change your entry as well, if you go here, if you highlight the consultation and you go on the blue hand and you again mark it as private, it will do the same thing as well. That it's a private thing and it asks you the same question as well. And if you do code it, it's very important to use the code of history of domestic abuse as opposed to domestic abuse. This is the safest code, which is advised by the RCGP. Even if the allegations, or even if the abuse is not historic, this is a safe code to put down there. History of domestic abuse, essentially, and then this is there. So yeah, so the GRACE tool and the documenting of this information is very important as well. Thank you very much. So thank you, Swati. So shall we take any questions now?
I think there is one, Raja, in the chat. I don't know if you can access it.
Yes, I can.
Yeah.
How do you combine the individual answers on the GRACE form into a single risk level? Yes. So I think, yes, I mean, I think you just need to, there is no score, there's no exact score here, which you do. And it's really about trying to, if I share my form again, apologies for sharing it again, but essentially, if you go back to the form, what you're doing is you just look at whether things are more on the right side column or the left side column. If it's high, it will become very obvious to you that there will be a lot more on the often and constantly one, or there'll be a lot more tick boxes here. While if you're more on the left side, perhaps it could be a medium risk or a standard risk. But there is no question here. I mean, the other form is the dash form, which is very lengthy. It takes a long time. This form was developed by Dr. James Findlay, a previous GP and my codenamed GP as well, who made it, and it's a very good form to use in primary care. A question for Swati. You mentioned to avoid the word alleged. Why is this? Swati, do you want to come back on that?
I think Swati got kicked out, Raja.
That's
and
fine.
She's trying
That's
to get
fine.
back in.
That's fine. So I can ask. So essentially, it's about trying to validate the victim here, because I think allegation implies that it might not be something true, and the last thing we want to do is make patients feel actually that they are not being believed, which is a very big reason why they do not approach a professional, whether it's the police or health one. So I think it's very important to not use the word alleged. Yeah. Thank you very much. Good. Any more questions for anybody? If not, we can take a break. Do we take a break for 10 minutes?
Perfect.
Yeah.
Yeah, I think 10 minutes is perfect.
All right. So we'll be back at 4:47 or what do I?
Yeah.
Yeah. Thank you very
much. In 10
much.
minutes time, yeah, we'll resume.